I figured out a way. I open up their SI joints, rotate their sacrum back, and boom, their pain's gone. But don't play by those rules. I need to know. I need to know that I have the right diagnosis. You just confirmed that that wasn't sciatica or knee pain or whatever they said. That was SI joint referred pain. You know for certain. Hey everybody, what's up? Physical therapist Dr. Ryan Whelton. If you're new to following me, I'm a physical therapist from the Tampa Bay Area. I got a clinic where most people have failed everything. When bone meets bone, it creates more bone. So you get bone rubbing against bone, and then therefore you get bone spurs, and we just so happen to have nerve roots there, and people can get arthritis and they can get pain amongst the bones rubbing against themselves, okay? In the facets or wherever. And so the hallmark for arthritis, a lot of this stuff you can diagnose before you even touch the patient. All you got to do is just listen and ask questions about when it hurts, the behavior of their back pain, right? So with arthritis, they're usually advanced in age. Usually you start to see it in the 50s. 50s a little young, but you'll see it sometimes. In the 60s, 70s, 80s, 90s, whatever. But what you got to keep in mind is that some people have a genetic predisposition to osteoarthritis, and it's rare, but I've seen it. And you see it in their 40s, stuff like that. It's like, wow, you have arthritis. Did your parents have arthritis? Yeah, pretty bad, that kind of thing. So arthritis hurts in the morning because it's stiff. So it's a fine line. People feel better with arthritis when they move, but if they move too much, then it hurts, right? But if they don't move at all, it hurts, right? So it hurts in the morning. And, I always say in diagnostics, the way that I think this through and the way that I do this is to rule out what you can rule out, and you can usually get to the actual diagnosis without imaging with that very high degree of certainty. So that's what I do. I just start ruling out what I can rule out. And there's only a few things left, right? So let's take the behavior of SI joint dysfunction, sacral torsion, sacral shear, which I am very vocal about the fact that I believe that is the most common cause of low back pain, especially low back pain that chronic low back pain that nobody knows what's wrong, okay? Because I got a clinic where most people have failed everything, and all day long I see SI joint, sacral torsion, sacral shear patients who have had failed surgeries, who are pin cushions, and they come in here, I open up their SI joints, rotate their sacrum back, and boom, their pain's gone, right? And that wasn't causing massive pain in their back. I put it this way, I have only seen, and I've only seen it once, I've been doing this 20 years, in the cervical spine, a true facet syndrome, and I was shocked at it. The person had radiculopathy. Now people can get like a kinked neck type thing, right? Or because the facets lock, right? The facets lock down on themselves, right? I mean, that's, loss of range of motion. But it's usually not like crazy pain, like that SI pain or arthritis pain can cause, right? So I do not think that is some major issue. Like I see all the time people saying it is, it's not. You can pop the person's facet and maybe it makes them feel a little better, but it's not causing massive pain in their back that they can't stand up. So I think that is way overdiagnosed. Spondylolisthesis, okay? Those patients obviously hurt with extension, and they will point over a vertebrae, and they will say that it hurts right here, and they'll point to it, okay? Occasionally, depending on how bad it is, you can get radiculopathy when you start to get to grade 3s, 4s, something like that. Herniated discs is another issue that can cause pain in the back. But listen, I believed what everybody believed, that I read these MRIs. Most of my patients have crazy MRIs, like severe, moderate, herniated disc, posterior lateral protrusions, right? But then I open up their sacroiliac joints and rotate their sacrum back, and all their back pain is gone. Yeah, they could have buttock pain from their herniated disc. They could have leg pain. I've had that, right? But it's not causing their back protrusions. Years ago, I started keying in on the fact that central protrusions, people would point kind of like spondylolisthesis. They would point over one vertebrae. And they would say, when they extend back, that they feel a pinching pain in their back. And I would match it up to the MRI, and I would be like, yeah, no, actually, that looks like it's true, you know? And with central protrusions, if you think about what's happening, it's abutting the thecal sac. That's the one on the MRI that I'm talking about, going straight back, not posterior lateral, straight back. And it's pinching the nervous system, so it causes pain, right? And though the behavior of those is it can actually grab you. Those people have more back spasms than most, I find, with that type of thing going on in their MRI. All right, so today, actually, I had a patient that came in. So today, I had a patient that came in, and she had, here's her symptoms. Back pain. She had back pain. She had right groin pain, okay? And she had, let's see, she had calf pain here, okay? And then she had foot pain, and she had pain over Achilles tendon to touch, right? And she's been to people for 3 years, and she said that they told me that I have Achilles tendonitis, right? Hurts to touch over their Achilles. I wasn't too sure about that. And I needed to confirm it was an SI joint, because your SI joint refers into your leg, okay? So Achilles tendonitis, but I'm like, well, I don't usually see chronic calf pain, you know, pain in the back of the calf here, from Achilles tendonitis. That usually doesn't happen. So I'm sitting there and I'm like, I bet you that's SI. So I have her locked up like that, so it's just going like that. So I pulled on her leg, I brought it back down, I laid her on her side, and then I went like this, and I gapped it open like that, okay? And she stood up, and the pain was still there, okay, on the calf. Her right groin pain, that she was calling hip flexor weakness pain, was gone. So when I did it on the other side, I opened up her other outflare, right? That was gone. So I confirmed what was wrong there, okay? And her back pain was gone. But she still had calf pain. And so then I had her squeeze a ball, do a ball squeeze with her feet close together, okay? So what I'm doing is that, gapping open, the outflare, and then it was still there, and then I just added a little bit of overpressure, gapping the ASIS medially, and when I did, I said, is that calf pain still there? And she said, no, it's not there anymore. And I said, okay, great. Now I understand what's happening. So she had SI joint dysfunction that was causing calf pain. She had true Achilles tendonitis. Okay, that wasn't a hoax. That was true Achilles tendonitis. She had foot pain because the physics of her ankle is off. We just need to fix that. And then she had groin pain because she was, she had groin pain because she had SI. And all the while she stumped the medical system, you know? But when you follow me and you do my methods, like, this isn't theoretical for me. This isn't like, oh, I hope I have the right diagnosis. No, we get. Annette, can you come here for a second? Okay, everybody know Vanna White of physical therapy? Annette, can you lay on your side, face, actually stand right here for me. Okay, so let's go over how, okay, and I pull on her leg, and you want her to slide like that. I pull on her leg, and then go ahead and stand up for me, please. And then arch back for me, please. Okay, now my left thumb's dropping. If it didn't, then you have to pull again. Sometimes you just didn't get it, or they were holding onto the table. Don't let them do that, okay? And then, but they'll still have pain if they have, especially chronic SI joint, they'll still have pain. So now we need to open up the, because it's tender on everybody, and I push medial on their ASIS, and you can feel the SI joint gapping like that, okay? And I'll do that for, I don't know, 20 seconds like that, and I'll get it moving. And then I'll say, go ahead and stand up for me, please. And I'll say, go ahead and arch back for me. And I'll say, is that pain still there? I do it on both sides. I gap both sides, out flares. And I'll say, is that pain still there? If she says no, then I know that it was SI joint, right? But if she says yes, I still have to clear the sacrum, okay? So what I do is, you can do prone press up test, or I put both of my thumbs right here and I say, go ahead and bend forward for me. I have my thumbs up. You can confirm that because her right piriformis will be weak in a 90-90 test. So test left, test right, and you will see the right piriformis significantly weak with the sacral torsion. If you are going to say that your right thumb dipped in, send me the video. I want to see it. I've only seen 5 in my career, and I do this for a living. Okay, so I don't know. I have a theory about it, but it's just a theory on why that is. Okay, but it makes it easier to teach and diagnose. Okay, so go ahead and lay on your belly for me, please. And you can have them do the prone press up test. Now, I put both of my thumbs on the ILAs, and I say, keep your butt relaxed and press up like a cobra. Okay? They have to keep their butt relaxed. If they don't, then then one thumb will pop out, and it'll give you a false positive as to what's happening here, right? So press up like a cobra. Okay, my left thumb's dipping in, go down. And now pushing this way. So I'm putting a downward lateral force, or a more anterior lateral force, kind of below, the force is angled right below the greater trochanter. And I hold that for about 10 seconds, and you can feel it. It's like molasses moving. And then I'll say, go ahead and stand up for me, please. And I'll say, arch back for me. And if they say the pain is gone, then I know that it was SI joint, sacral torsion, sacral shear, which it usually is. And then, but if the pain is not gone, and let's say, like I have a patient right now, he's got pain all up his back right here. The SI joint pain went away down here, but he's still got pain here. And without imaging, I'm wondering what that is, right? And it's not facet syndrome. And he doesn't have multi-level spondylolisthesis. Never really seen that. And it's not herniated discs in his spine. And what he has is actually arthritis in there. So how did I come to that conclusion? Is because he doesn't have SI joint anymore, and he's still got spinal pain in extension, and he played hockey his whole life. So people that are super active, congratulations, you're in your 50s and you already got arthritis type thing. Plus, I have a way to check it with electromagnetism that I discovered, and I was able to relieve it using a certain frequency, and I talk about my VIP inner circle, which confirmed it to me. So thank you, Inette. So when it comes to diagnostics, you rule out everything, okay? Everything that you can rule out, okay? And you can CT, okay? Peace, love you all.